Welcome everyone to the third annual EMS Leadership Summit. My name is Robbie McHugh, and I'm happy to be with you today on this live stream opportunity with a phenomenal speaker. But I want to ask you, did you know that there are more safety regulations for cattle trucks on the road in the US than regulations on ambulance vehicles? In this session of the EMS Leadership Summit, we're going to talk about the last 20 years of safety research and what's changed and what hasn't changed. I'm your co-host on today's summit and thrilled to introduce you to Dr. Nadine Levick. She's an emergency medicine physician, clinician and researcher, and real innovator. She's fluent in the interface between medicine, healthcare delivery, science, engineering and technology, and community integration. She's conducted the first ambulance crash tests and has an inaugural National Academies of Science, Medicine, and Engineering EMS Safety Committee chair as well. She's established the internationally known EMS Safety Foundation, a think tank and knowledge portal online, securing over $4 million in funding for interdisciplinary research and innovations. So she has her career span has spanned 3 continents and disciplines for decades and impacted policy and a practice internationally. So I'm thrilled to introduce you to Dr. Nadine Levick. Nadine, welcome.
Hi there.
It's great to see you. All right, folks, and people can see the screen. And if you're joining us live, feel free to chat below with where you're joining in from. We'd love to see what city, state, and country you're joining in. Nadine, we've got folks from 44 different countries that have joined us in this last week. So
wow,
truly to have you here streaming in from Israel and around the world.
Thanks so much. We're ready to roll.
All right.
Thank you very much. It's a real privilege and an honor to be joining you guys again here from Israel and to be speaking on safety in EMS and looking at innovation. And really what I want to focus on is the future is now. Before I go forwards, I just want to thank many people, those who've contributed in time and technology and ideas and effort to the EMS Safety Foundation. And also all the work by those who've been involved with the National Academies of Science, Medicine, Engineering, Transportation Research Boards, AMB 10.5 EMS Safety Subcommittee. So what I'm going to talk about today is one, the future is now, our new world order, cross-skilling industry and providers, some innovation dimensions, and that sometimes cheaper is better and safer. We're going to look at some open source and some challenges. So first of all, what is safety? And I think it's always good to have a clear idea of what it is you're focusing on. And it's really protecting against undergoing or causing harm, injury or loss. And as I sit here and speak to you today, I'm 36 kilometres from the Gaza border. And this evening, the Iron Dome did take out a rocket heading my way. So that's an example we're going to focus on in a minute. And what's innovation? Well, something that's new or original and ideally more effective. So right now, there are many things out there that we could be doing and we're not yet doing, some that we are. Here's just a little window of what we will be doing, and space-based solar power, million-mile batteries, eVTOL, hydrogen power, mixed reality, to just touch on a few things. And here's an eVTOL vehicle that's being developed a few kilometres up the road from where I am here in Israel. This is being developed in Yavne, which is just up the road. And here's a virtual reality setup on a telepresence robot. So we definitely are looking at fleet mix differently, not only just the usual, are we using motorcycle, medic, segways, other things, but vertical takeoff vehicles, drones that are manned and unmanned. We've got these smart technologies now, AI dispatch, AI ultrasound, voice-activated commands, advanced smartphone technologies, mixed reality, integrating our training and even our intervention. All of us are dealing with COVID, PPE and innovation in that field, and connected health is now a reality for many of us and something that can really enhance the quality of care that we provide. Wireless patient monitoring, well, we're not that far away from wireless monitoring being placed on the patient even before the EMS arrived and carried right through into the emergency department, and health information exchange applications. So we need to be ready to deploy new and effective tools for both training and operations. These new solutions touch on training and education, operational tools, innovation in how we protect ourselves, the types of vehicles we use, AI support for our tools and adjuncts, everything from dispatch to ultrasound, engaging the community as part of the system, and really the scope of practice. And I know that my colleagues have touched on community paramedicine, etc. This has to be my favourite quote in the world, and it comes from Colin Powell. And I'm going to read it. I hate reading slides, but I'm going to read this. Being responsible sometimes means pissing people off. By procrastinating on the difficult choices, by trying not to get anyone mad, and by treating everyone equally nicely, regardless of their contributions, you simply ensure that the only people you'll wind up angering are the most creative and productive people in the organisation. And last year, just before I spoke, I had the privilege to listen to Chris speak, and he made two really key points. One, that leadership is not a position, it's about professional development. And leadership as a verb, it's an action, it's not a position. And everyone will influence someone else, both for the good and the bad. So it's really important to harness leadership in the most constructive and positive way, to empower everyone in your organisation and to focus on positive empowerment. And now we have a new world order. It's a year since I spoke last time, and a really difficult year for everyone. Just 2 days ago, the CDC put out their pandemic occupational recommendations. It's a completely different world. Speaking to some of my colleagues at the hospital today, and one of the people I was speaking to was actually the mother of a nurse, and she said, she's terrified for her daughter going to work. And it was never really that situation for first responders to be in that sort of fearful situation for themselves and their families. And it is a new world order, and we're facing challenges of a magnitude and a nature that we haven't faced before. Given that today is September 12th, I just wanted to take us back to September 11th, 2001, and probably pretty much in America, everyone in America remembers exactly what they were doing that day. Although I was living in New York then, I wasn't in New York. I was actually in Tempe, Arizona. And by a chance of fate, it was the day that we'd chosen to hold probably one of the world's biggest military and emergency vehicle safety symposiums. And so there we were in the middle of Arizona. And for those of you who aren't from America, it's like bang in the middle of America, reasonably isolated. And we brought together the military and all emergency services, police, fire and EMS, to talk about vehicle safety. And those are the issues that we were going to talk about. And because Arizona is a few hours behind New York, it was still dark when the first plane hit at about 9:15. And we didn't know whether we should just go ahead or not. And we decided that it was in the interest of all emergency providers to go ahead with our conference. No one could go anywhere anyway. The skies were shut down. But what I wanted to, and so it really was a very solemn and extraordinary experience to be in an audience of military and EMS personnel all trapped in Tempe, Arizona, doing what they could to try to create a safer environment for first responders. But what I wanted to share with you was just 2 slides that were from 20 years ago, looking at what we thought the needs were. And as I prepared this presentation, I was really struggling to find an accessible database of the morbidity and mortality of first responders, EMS, fire and police related to COVID. And to see 20 years ago that we were saying we need a morbidity and mortality surveillance system, that we need to have national, international collaboration, that we need to have proper funding to support these initiatives. We need to have a defined pathway for translating problem identification to resolution and policy implementation, and a need for an appropriate overseeing infrastructure with development of safety performance standards. And 20 years ago, they say it takes 20 years to make things happen in medicine, to translate research into practice. And it sort of was very solemn to read that slide, which I hadn't looked at for 20 years, and this one, and that we should be focused on the safety of all aspects of the ambulance environment and really looking at it as an all-hazard situation. I'm going to touch on that again in a moment. And that to identify and acknowledge that there are real dangers in some of our current practices and that safer practices exist and should be used. And then I made a comment about the importance of doing the right sort of testing to provide automotive safety. And then that collaborative, interdisciplinary approach, bridging all the involved disciplines, everything from biohazard to ergonomics to automotive safety, so that we can design emergency vehicles in a way that they do provide a safest possible environment for providers and first responders, and that we need to have some standards for safety of transportation. So 20 years ago, so I was pleased to see that the EMS agenda for 2050 has come out, and it's focused on these 6 areas being adaptable and innovative, inherently safe and effective, sustainable and efficient, integrated and seamless, socially equitable and reliable and prepared. So there is now a more coordinated focus on these areas, although we're still lacking in true safety oversight. Another of my favourite quotes, and it's always great when you can quote someone from industry making a social good statement. And Joe Bullgraff's a particularly unusual, innovative person from industry, and his comment is, to create an innovative and model EMS system, we must engage in a collaborative and cross-functional conversation amongst the many contributing partners in the EMS industry. EMS suppliers should embrace and drive new innovation to improve the process and efficiency of delivering service while advancing the level and the outcome of emergency care. And outcome of emergency care is definitely where we want to be aiming. And not everything needs to be high tech. You know, there are some low tech initiatives. I'm going to touch on a couple of them. But we need to be thinking with a mindset of a system of safety, thinking of the overall impact of a change you might want to make. And some small low-cost changes in practice can have significant benefits to outcome and safety. We want to look at policies that augment safety. You know, AMR has long had policies about not driving through a red light, that you must come to a full stop. Innovation in design from micro to macro, and preparedness and training. And the focus should be safety of the provider, the public and the patient. And if there was ever a time where the safety of the provider was really paramount, it has to be now. And really, safety is a tool that's going to save time, lives and money, but it must be evidence-based. The goal is that we're going to work smarter, not harder. So we want to do the right thing at the right place, at the right time, for the right person. How is it that we can best achieve these goals right now and also for the future? So what I really see as the frontier for EMS safety is that interface of disruptive new tech and operational practice at all levels of the EMS system and across all the disciplines, whether it's biohazard, whether it's physical issues or priorities on policy. I just want to spend a moment talking about this Gartner's hype cycle. And it's really a tool that looks at change, adoption and sustainability. And it sort of has an innovation trigger, and then a sort of peak of inflated expectations, and then a bit of a trough of disillusionment, and then slowly progress into productivity. Well, in 2017, we saw things like autonomous vehicles coming up, and virtual reality were just appearing on the scene. And by 2021, those autonomous vehicles and virtual reality, they're out there now. They're no longer even in the development stage. People are using these tools. They're using them in EMS. We're going to talk about that in a little. Really, where there's a big focus now is on fine-tuning AI and looking for where AI can have major impact. And we're going to focus on a couple of examples where AI and EMS interface. So this is an interesting sort of chart that's trying to focus on what we can do right now, which is the little yellow part, and what's coming up in the near future, and that's the rings around it, and the sort of impact it's going to have. And Gartner are very good at putting these together, and it's very clear that, and they've got these into a number of different domains that affecting productivity, looking at a number of different aspects of operational protocols. And it's a very helpful way to try and look at how you're going to direct your engagement in new technologies. And this is their projections for the next couple of years of an emerging technology roadmap for mid-sized enterprises. And I won't spend too much time on that, but these are actually really valuable tools so that you can try and look at very objectively at what are the technologies out there and how they can potentially impact your organization. Because in the 1980s, some of us may remember this thing was actually a cell phone, this heavy, big brick. And here now, many of us answer our phone from our wristwatch like the Jetsons. But in 1980s, this was an ambulance, and in the United States. And in 2021, pretty much in many places, not all, it remains an ambulance. We're going to talk a little bit about some of the biohazards, ergonomic hazards, and automotive hazards of that environment. And, you know, it's always nice when you can quote something from 1687 and Newton's principles of physics do prevail. You know, it's not a new question. Back in 1864, first responders were really looking at how to improve the safety of the work environment for the provider and the patient. And this was obviously in a horse and buggy setting. So if you were to ask people how to enhance safety and efficiency back then, they'd probably say, oh, more rest stations. They would be most unlikely to say develop a combustion engine. And I doubt they would have said, how about a hydrogen-powered eVTOL? So I'm going to come back to this. Ambulance transport safety is part of a system. The overall balance of risk involves the safety of all the occupants, patients and provider, as well as the public. So how does design in EMS happen? Well, often tradition has a lot of impact on what is undertaken. Experience, vision, and interdisciplinary collaboration, we're starting to see a little more impact of that. And, you know, my dream is that pyramid flips upside down and that tradition gives the least impact and experience, vision, and interdisciplinary collaboration are the sources of innovation. If we look back in the 60s and 70s, safety really was not a focus. It was just delivering care with what we knew, the tools and the techniques. By the 80s and 90s, there was concern about safety in EMS for the providers, as well as the patient, and maybe the public. But there wasn't much guidance as to what to do, wear gloves. And then in the past 10, even now 20 years, we've started to see a lot of technical safety data roll out. And the real challenge now is how do we adopt and integrate what we now know into our everyday practice? So I really feel, as Robbie said right at the start, that we need to be looking at an all-hazard safety approach. We need to want to design an operationally safe system. And from a multidisciplinary hazard analysis perspective, clearly now everyone's very aware of biological hazards and, you know, rapid adoption of whatever we could do to improve the safety for the provider in this setting of biological hazard and pandemic. But there's biological hazards, chemical hazards, physical hazards, psychological hazards, and operational hazards. And what we really want is applied use of state-of-the-art technology to address and neutralize or minimize these hazards in an all-hazard manner. Yeah, as I sit here in Ashdod, 36 kilometers from the Gaza border, this is May this year, and these are some rockets being fired out of Gaza. And we have a thing called the Iron Dome, which is designed to take out the rockets before they hit buildings or people. And this is the Iron Dome responding to those rockets. Actually, they say you're really an acclimatized Israeli when you can tell the difference between the sound of the Iron Dome taking out a rocket or the rocket being missed by the Iron Dome and crashing into a building. I'm not sure that I can tell the difference between those two sounds, but I sure know what it sounds like when the Iron Dome takes out rockets, and I've got a fair idea what it sounds like when the rockets hit. Actually, when the day this was taken, I actually found a big chunk of shrapnel next to my car the next morning, and I think it was the Iron Dome had taken out a rocket just above my building, and the shrapnel fell down. So tonight's an interesting day, September 12th. We're meant to have a ceasefire, but the Iron Dome's been busy today for the third night in a row. So if there's a sudden break in this presentation, it's because there's been a need for the air raid zone to go off. So far, so good. So COVID-19, the 2020 onwards pandemic. When I spoke last year, I was able to say that there's been a tenfold increase in out-of-hospital cardiac arrest deaths, and really seeing new patterns of morbidity and mortality for EMS to deal with. And without a doubt, EMS personnel are even now vaccinated, etc., are at high risk and, above all prior occupational fatality risks in the setting of COVID. Finding comprehensive national data or definitely international data is really difficult. But there have been, as we saw, last year, by April last year, just in New York alone, in the Fire Department of New York, there were 8 active duty deaths by April 22nd last year. By April 28th, there were more than 24 COVID deaths in USA. And this is before we had a vaccine. Then between March 2020 and September 2020, there were 36 COVID deaths in New York City alone. And by late last year, entire EMS services were being quarantined. This is an unprecedented situation from the point of view of biological hazard for EMS. In January this year, we had our first responder COVID-19 registry in North Carolina. So, solutions are out there: protective equipment, hand washing, patient barriers from high tech to low tech, and people are looking at air filtration systems as well. The first 2 or 3 items are really not new technologies in the real sense of things. And when we look back to the Spanish flu, PPE and hand washing and patient barriers were all they had. And so this is how EMS looks now in the middle of a full-blown wave of COVID here. And it's time-consuming and also cumbersome doing this compared to how EMS has accustomed itself to work. And last year we even saw some shortages of PPE. So we see initiatives like this, and I think these are creative ideas. I often wonder, what is it that you need? What are the design constraints for something to provide a sort of barrier for the patient and the provider? And I suppose you want something that's easy to get the patient in and out of, something that will contain aerosol pathogens, something that's tolerable for the patient and cleanable or disposable. You want it to be cost effective and time effective. And I really ask, does the whole patient need to be contained when it's pretty clear that most of the COVID transmission is respiratory? So, these are big and they're cumbersome and they're expensive. And I think there may be some more simple ways that we're going to look at shortly. Air filtration systems, well, we just want to know that they work, that they're practical, that they're effective, they're cost effective, and that they fit in with the system of solution that you have. Other things are very basic, challenging, design-related human factors. Not only is this equipment hard to reach and puts you in a bad situation, but it puts you right over the patient's expired airway. And it makes no sense to have an EMS provider with their face right in the face of the patient, exposing them to biological as well as the obvious ergonomic and automotive hazards. So we've got new tools, we've got new vehicles, we've got new industry relationships. There's stuff that we know, safe systems, risk perception, fleet operations and management. We know some elements of vehicle safety and vehicle design safety. We know a fair amount about how to be safe at the scene, a particular roadside scene. And we've got a reasonable handle on these areas of physical and biological hazard, our health and wellness as providers, and an understanding of hours of service. I just wanted to take you back, after going back to 2001, I'm going to take you back to 2012 to the TRB EMS Safety Summit. And this material is all fully available. All you have to do is scan this QR code with your smartphone, and you'll have this interactive infographic, which you could share all the presentations of that TRB summit. And we covered the full gamut of EMS safety as it was known then, and this is 2012. So we talked about some data issues, human factors, testing and standards, some of the new safety technologies and solutions, some fleet management tools, innovative vehicle design, operationalizing safety, and a really fantastic wrap-up from Art Cooper. So if you don't want to listen to anything else, just listen to the fantastic wrap-up from Art Cooper. That was 2012. Well, here we are now. We've got lots of new technologies. We've got truly innovative fleet management tools operating out of the cloud. We've got diverse vehicle types and designs and drones. We've got robotic tools. We've got AI augmented dispatch, AI augmented ultrasound, mixed reality, AR and VR, augmented reality and virtual reality, connected digital health, information in the cloud and the crowd. And all of that we need to harness, and that's a lot of new stuff. So fleet telematics tools, they're getting more sophisticated by the day. I think that it's now possible to link your CAD with Waze so that you know exactly what sort of road conditions you're going to be facing when you get where. And then again, getting back to that, how much information do you need to have a good outcome? And sometimes even a minimal amount of telematics data, if it's sophisticated enough, will give you good information. And here I just mentioned a moment ago, integrating your CAD with things like Waze, so crowdsourced data. Actually, Waze was also developed in Israel. And if you've ever been on the roads in Israel, you'll understand why Waze was developed here. And this is Genesis Pulse, integrating crowdsourced Waze data into your CAD so that you're able to provide the best information to your fleet. Here's another very interesting integration of crowdsourced data and EMS. And this is a paper written by a colleague of mine here in Israel from Bar-Ilan University, David Schwartz. And he actually was involved in crowdsourcing Narcan so that the people who were likely to be near somebody who was likely to need Narcan were able to get the Narcan to the patient whilst EMS was on the way. It's a very nice paper just published last year. And again, engaging bystanders with cardiac arrest. Never have I seen a more elegant illustration than this that shows the benefit of bystander defibrillation in cardiac arrest from Denmark. And Wearable Tech, as I mentioned right at the start, there's going to be a time now where when you arrive at the patient's home, they're already wearing their monitoring equipment. They've got some Band-Aid that will give you all your vital signs that you need. And en route, you'll be able to capture all that information so that everything is available the minute the patient gets in your vehicle and is brought into the hospital. Lots to learn from our international colleagues. One of my favourite photos with AJ Heitman and Scott Craven, and here at Retmobile with Professor Sefrin, who's a brainchild. Retmobile's his brainchild. Clearly with COVID, we haven't had Retmobile last year. But I love this this illustration here. This is the old expensive technology, the LED gauge. It's giving you time and temperature. And here's the new technology that's able to give you everything from a roadmap to an EKG trace wirelessly fed off the patient. It's cheaper, it's better, and it's way more versatile. So we're going to start seeing these sorts of technologies in EMS that are cheaper, better, and way more versatile. And just a couple of design features. Getting back to what I said before, there's no need for the provider to lean across the patient. Everything they need is right at their arm's reach, and they can stay well away from the patient's expired air. And here's just another example of that. And this is very different from what we routinely would be seeing in the United States. Fleet mix, well, all sorts of vehicles out there, whether it's a gator, motorcycle, bicycle, Segway, all sorts of ways of reaching your patient, and a number of places now have motorcycle medics. We have a number of motorcycle medics here, both with our Mada and our Hatzola, and really pleased to see that we actually have a fleet of female motorcycle medics. And here is the first Muslim woman to ride a medical motorcycle, which is really cool. But not everything's got to be fancy. This is from my colleague in Malaysia. This is Dr. Sarah, and sometimes it's simple things can be cost effective and a great innovation. If you don't have the resources to have a bunch of wheelchairs, you can make nice ones out of a pool chair. And this is another of my favorite simple innovations. All of you who've tried to open a zipper with one hand, very difficult. This very simple thing here, little piece of silicone, just fits onto any zipper, and you can with one hand open or close that zipper. So again, not all innovation is complex. And here's another of my favorite simple innovations: patient transferring slides, cheap, simple, and easy to store. And in the developing world, we see some other interesting initiatives to create a patient transport vehicle with some very simple tools. So I'm going to spend a moment now talking a bit more about some Israeli innovation, because that's where I am. And this is probably the most extraordinary thing. I've seen many extraordinary things in Israel, the Iron Dome. If we didn't have an Iron Dome, 90% of those rockets, if not more, would come through, and EMS would be overwhelmed, as well as the emergency departments. So this extraordinary building is the brainchild of a brilliant paramedic, PhD Dr. Oren Wacht, and he is almost single-handedly put together everything that was needed to be, including a massive application to the then president of the university, Professor Rivka Karmi, to get the funding to build arguably the most high-tech, impressive EMS simulation and training center in the world. SIMREC is actually opening officially next month, and it is without a doubt the most extraordinary initiative I've seen when it comes to EMS training and education. Clearly there'll be other areas of healthcare that will train there, but this is a 3-story complex built with world's best technology integrated to have training and education for EMS. And I imagine folks will be coming virtually or otherwise from all over the world to be training there. And I'm hoping, Robbie, that we'll be able to give one of these presentations from there also sometime. That would be really cool.
That would be very impressive.
To I can't speak too highly of Oren's work. It's amazing what he has done. The effort and the focus on having the world's best center for EMS training, and this will be very exciting over the next few months. So I really wanted to thank him for his extraordinary work, and to thank the vision and the innovation of Professor Rivka Karmi, who actually is the first and only woman president of a university in Israel. She did retire recently, but this has been their brainchild, and just remarkable to see that effort and that focus. You know, it's not like a back room for EMS anymore, and it really puts state-of-the-art EMS training on the map. So congratulations to Dr. Wacht and Professor Rivka Karmi for having made that happen, and all the people who were part of making that happen with them. And very much look forward to sharing more information about that with you. Israel's a place where innovation is a necessity, and that's why Waze was developed here. That's why Skype was developed here. That's why the Iron Dome was developed here. There are two main ambulance EMS services in Israel. One is the state-run Magen David Adom, and the other is Hatzolah, and they both provide incredible service in multiple types of scenarios, and working very closely together, particularly when we have a disaster situation that needs that. And have a spectrum of different types of vehicles. One of the things I really wanted to share with you, and I shared it last time, and it remains extraordinary in my mind, is that they have an app, and many people have it downloaded. All the EMS operational people have the app downloaded, but people can interact very, very easily. And it has Scene Video Connect, so that dispatch can always actually see what's going on at the scene, as well as some of the EMS physicians are also able to interact and see visually what's going on at the scene. Very impressive dispatch centre. If you're ever visiting Israel, you must come and see what they do there. And last year, we had 2 years ago, my first experience. I'd only been here for less than a year. We had about 600 rockets in 36 hours, and thankfully the Iron Dome took out 90% or plus of those. And May this year, 2 years later, we had another experience like that. But people are very well trained here, and the training that they have here is also shared with others throughout the world. And again, cheaper, better, safer. A lot of money isn't spent on moulage. They have these really cool moulage T-shirts. So people just put on the moulage T-shirt, and it's a really quick way of getting everyone moulaged up for a training scenario. We've got some new models for Corona, and the video interactive telemedicine support is there for patients who could maybe be discharged home by EMS. This does look like an EMS triage, but we've had a lot of elections here. I think 4. But this is actually a voting booth, and as you can see, people take PPE pretty seriously when there's a volume of people coming through. And I just wanted to highlight that getting hold of toilet paper was not a problem. Here are the military giving out food packages and toilet paper packages to areas where people might have had some difficulty getting to the store. It's also a very multicultural service, and I suppose most folks don't realise that there's a very, very diverse mix of cultures in Israel, and about 20% of Israelis are actually Arabic Israelis, and many actually work with Mada and also fight in the army with the Israeli Defense Force. So a few words about some innovation. Well, I said I'd talk about it. So something simple like this may be a better solution than those big plastic coffins I showed you earlier. This is made by Furno, and it's just a foldable, like a fan almost, COVID shield that covers up the respiratory part of the patient. So that looks like a practical solution. And what we started to see when there was some shortages of oxygen delivery systems, a bit of cross-skilling with industry, and the people that make SodaStream decided they could make an oxygen delivery device, and some very interesting innovation came up there. The other issue, we're starting to see a lot of ultrasound use in EMS. We're seeing extensive ultrasound use in emergency medicine, and there's an increasing role for ultrasound use in EMS. I couldn't possibly give a presentation without mentioning the in demo unit, the Ambulance Safety Innovation Design module, and here it is there. Hasn't quite made its way to Israel yet, but we're working on it. And it shows a couple of interesting things, this sort of compact environment where you're not inhaling the patient's expired breath. And also initiatives like this rollout pack. If you need to take your equipment to the scene, you can just unhook that from the wall and take it out there. And also configurable arrangement. If you have a mass casualty, you can just flip out the chair and put in an extra stretcher. LED lights, again, simple, $20 worth of LED lights. You can actually see where the stretcher's going at night. Fewer tripping injuries and probably fewer dropped patients. Voice-activated commands. Even my 90-year-old mother has an Amazon Echo Show. She actually has 4 of them in her home. And voice activation is out there. It's in the community. We should be using more voice-activated commands so that our hands are free. And the in-demo module has voice-activated system in it. I want to spend a moment talking about the virtual world of mixed reality, augmented reality, and virtual reality. There are a number of applications now out there where these technologies are being used in training both providers and also the public. Some CPR training in the United Kingdom, and in Australia, some aggression management for EMS providers, as well as VR patients, which is a new tool I'm going to spend a bit of time on. Here's one of the examples of VR training for ACLS. But the next level of VR training is scenario authorable by you. And with virtual reality patients, you can actually author the scenarios that you create. You've got all the tools to put them together. It's actually quite an interesting tool. It's just as simple as making a PowerPoint, and it has built-in evaluation. And these are some of the modules you can build from. And that's the actual build process. I actually, with almost no training at all, you can actually build a training module for use with your providers. And here's some of the sample tools you can put in: avatars for children with equipment and engaging the provider with the equipment. And it's all very interactive. CPR training I mentioned in the UK, and the violence training in Australia. Here is a group called Real Response, and they're doing some mass casualty training in the setting of, I think that scenario is a hotel scenario, and that's Neil Blackington in the background in Dubai, actually pilot testing that. So we're looking at tools that we never used to have. We definitely didn't have them 20 years ago. We can also use virtual reality as a design tool as we design the interior of an ambulance. We don't have to physically build it. So, autonomous vehicles and drones. So, vertical takeoff vehicles, I mentioned them right at the start. Unmanned ambulance drones for delivering defibrillators, manned drones for responding to an emergency scene. This is a viable drone built in Asia. And, could this be the ambulance of the future? Or should we be looking towards this sort of vehicle? This has internal rotors. This is back in 2002, year after September 11th. And 2020, nearly 20 years later, they're looking for a deployable device for an EMS purpose. This company, another Israeli innovator, they're actually just up the road from me, about 10 kilometers up the road in Yavne. And here I am checking out their prototype operational unmanned drone. And here it is in the air. And again, something that's been considered as an EMS vehicle. They've just now deployed their hydrogen-powered eVTOL, and it's currently undergoing some testing. We saw this. I don't know that I'd be in a hurry to do this, but this is a jetpack that seems to be operating from this young man's arms. So AI, the good, the bad, and the ugly. Well, AI and EMS, we're starting to see AI integrated in triage at a number of levels, integrating augmented dispatch. And a very nice paper by Freddie Lippert said that AI is good, but so are dispatches. So we have a fair amount to learn here, but I think we're going to see more and more applications. And AI ultrasound and EMS clearly is an area that's going to rapidly develop. But AI, it's a work in progress. Just a few days ago, we had the 12th Tesla and emergency vehicle collision. AI is only as good as the algorithm, and it takes time to get those algorithms right. And clearly, we're all told these are not autonomous vehicles, and it appears to be that in these settings, the Teslas were being used autonomously. So I get back to what I said I'd come back to, that ambulance transport safety is part of a system, and the overall balance of risk involves the safety of all the occupants and the public. So our challenges today are adopting new technologies and practices that augment EMS performance and safety, embracing decentralisation of healthcare, doing more with less money and less workforce, cross-skilling EMS industry and the community, and making sure that we've got systems thinking and practice, not just focused on one element. Because things can go wrong. And when we have sound safety policies and technologies in place, and the system is well prepared, you can minimise harm. And this was quite an exciting day in New York. So what we want to have is an all hazards approach, not just a piecemeal approach. Technical collaboration is key. We just can't afford to play the silo game. It's costing us lives, time and money. We must have meaningful, evidence-based approach to design, operations and policy. And we must be focused on true outcomes. So to wrap up, the future is now. All hazards approach is key. Safety must be inherent to operational process, design and practice. We've got to work out a way to adopt and deal with the challenges of new disruptive technologies and the applied innovation that exists out there. Cross-skilling industry, providers and the community is increasingly important. And the interplay between the patient, the provider and public safety from a systems perspective is key to effective and safe operational EMS performance. So that's it, folks. Your electronic handout awaits you at this link, and thank you. And I'm here live, so you can even ask some questions if you have any.
Nadine, that was brilliant as always, and I love your closing remarks about this systems-based approach to not only design but safety, and having all hazards, all folks on board to resolve these issues and innovate. Dave says he remembers you speaking at Medic Update years ago, and when you mentioned going to a European van-style ambulance, heads exploded. And look at what services are using now. Other folks are chiming in, saying Dwight says that the modular ambulance is one of the biggest complaints in the industry, or his biggest complaint in the industry, and he's got a service, knows of a service that's working really hard to change the design and the status quo. And I believe that Butler County EMS system switched to the Ford Transit style ambulance, right, as I saw. Some other questions here. Eric Chase is asking about, let's see, he's basically asking about, I think, the Gartner hype cycle when it comes, when it comes to how do you quantify what's in the near future in years until implementation? He's asking, like, from the feasibility to the implementation, does every technology maybe have a different life cycle?
It's an interesting question, Eric. From watching what the folks at Gartner do, they occasionally will focus their hype cycles in different areas. Like sometimes they'll focus it on healthcare, or they might focus it on emerging technologies, or they might focus it on blockchain. And when you look at the more focused hype cycles, I think what they try to ascertain there is some understanding of implementation and deployment for a technology that may well be effective. Healthcare is a sad story. COVID's just such a great example of how to get past it. But historically in healthcare, it's 20 years to get a proven intervention into practice. And as much as COVID's been a horrible challenge for so many of us and a really, terrible experience for the world, it has shown us that you can be more nimble in healthcare. It has shown us that you don't need 20 years. It has shown us that you can do things really quickly and get good outcomes from your intervention. So I think that, that's probably the one upside of this experience, that it's really shown healthcare that you can be nimble, you can be quick in identifying effective technologies and deploying them. Sometimes you're not always right, but clearly developing of vaccines and delivering the vaccines to the society was pretty impressive. It's never been done. I don't think it's been done in history before. So that was great. But great question. I think it's a real challenge to foresee the future. You always had that problem. What did Bill Gates say? The world only needs 4 mainframe computers. It's really hard to predict the future. It really is. But whoever made the Jetsons really had a great handle on predicting the future. Sort of impressive. They had those EVTOLs sorted out.
And Dwight mentions about crew resource management, and he did a ground critical care for a pediatric hospital. I think he was saying it was maybe interfacing with Hatzola, and they treated their ground units similar to their air units. There was crew resource management, frequent check-ins, 2 to go, 1 to say no. And you just can't understand why more organizations aren't using this in their ground systems.
Yeah, you raise a really important question. There was a great program out of Duke that did integrate crew resource management with their EMS, modeled on their air EMS system, and found it really valuable. So, my feeling is that those folks that are doing that great work and applying those models, the more outreach they get and the more people hear about it, the better. And that's what your organization is doing, is making sure people hear about cool stuff that works.
Well, that is our goal. Again, having participants from 44 different countries attend in this last 7 days has been just an honor to create this platform as a stage for innovators like yourself and so many other people. Lisa Rainey, one of our speakers, she's actually working. She just comments below. She's going to be with us on a live panel in a little while, but she's saying that she's now working with the VR training at Health Scholars too. So,
yeah, I think I had a little slide up about those guys.
Yeah,
that's great to hear.
Well, you've got a lot of folks saying thank you for your presentation.
It's a pleasure.
Folks from around the world chiming in, from Kenya as well. So it's great to have the interaction. We appreciate your time, Nadine, and thanks always for being on the cutting edge.
Sounds great. Great to chat with you all, and wish you a safe remainder of the year. And I hope that we can, as rapidly as possible, translate all the important and valuable technologies and approaches, just as Dwight has said, into our operational practice. Absolutely. So great to hear that.
Folks, we are on day 5. We are on day 5 of the EMS Leadership Summit. You could still go to emsleadershipsummit.com and grab your free pass to the conferences. There's still time to grab an all-access pass if you wanted lifetime access to all these wonderful speaker sessions. I want to thank Dr. Levick for her time and beaming in from across the world. And we appreciate her. So
thanks so much. Thanks, Robbie. It's great to be here.